Good afternoon. First of all, I thank the organizer, especially PVR sir and Himanshu and Ashutosh for having me here. So I'm from Trichy, Tamil Nadu. I'm there practicing there for 25 years. I graduated from IKDRC. So my topic is AVF aneurysm, which is quite not, the definition is not very standardized, and even treatment protocol is not standardized. When I gone through the I just hit the YouTube or some sites in the Google, I could not find any comprehensive approach towards AVF aneurysm. Everything there's a case reports, authors, individual authors' opinion. Just based on my practice and some literature available, I formulated this talk. I hope it will be useful. And so AVF aneurysm, it can be simple, any AV fistula is aneurysm only, right? So it's kind of, they say that 3 times the normal size vein or 18 millimeter more than the diameter, it's called AVF aneurysm. It could be simple host type to hem will come to, a giant venous aneurysm, otherwise known as python, or a serpentine, monstrous, there's people, so many names they're calling it. So these are some of the pictures I got from Dr. Girish Reddy from INU. So just 5-6 slides, you see which variant is causing AVF aneurysm. So I just go rapidly because my time is limited. So all this, just have some kind of a memory in your mind and calculate how many BCF AV fistulas causing AVF aneurysm. So most of the case we encounter in our practice are basically from BC brachiocephalic AVF. Very rarely we see from radiocephalic. So this thing. With this, some pictures, I'll go into the talk. Okay, aneurysm divided into true and false. False, we know simplistically it's a hematoma communicating with the lumen. Over the time, it becomes a fibrotic sac without a wall. It would be focal at the point of needling or where an intervention is made, or at the anastomotic site. Mostly we see in 30 days, 40 days, AV fistula is infected. The true aneurysm is external abnormal remodeling due to Alport syndrome. In case of Alport syndrome, ADPKD is genetic one. Downstream stenosis may be the injury, but most of the time we don't know the cause, how it happens. Here the whole flow, outflow vein can be or focal. Here the focus. So the causes could be generally injury, remodeling, and downstream stenosis. The most common is areas of BC AVF and RC, then brachiobasilic AVF. So pseudo-aneurysm, we call this AVF. Pseudo-aneurysm is a common abbreviation we use it. Anastomotic site and along this. So anastomotic site, the presentation would be non-tender, painful swelling, sometimes progressive, signs of inflammation. Sometimes you will see eroded skin with telltale signs of impending rupture or blowout with bleeding. This is a common presentation. So this is one case, a 22 years old fistula, days fistula, just a swelling spotted by our staff. Then with ultrasound showing pseudo-aneurysm. So this is what the thing. Ultrasound is a handy, and we just it is a basic side-to-side brachiobasilic fistula. So this is one, and intervened preemptively, and both arteries were tied because I think mostly 99% is all infection only. So this is same picture, right? This is another impending rupture, identified before rupture. Another case. So this identification is very important. Pseudo-aneurysm. This is a blood and stopped. The another case, lost 1 liter blood during sleep. So he came and we intervened. This case was non-infected, and the aneurysmal mouth was closed, and a fistula was sacrificed that day. So pseudo-aneurysm often display yin-yang phenomenon, and this is a common finding, very interesting finding. We can even teach your staff to find out the early things. So pseudo-aneurysm along the course, mostly it's a needle injury. So this is what happens right then. So this patient, one patient, we had a pseudo-aneurysm along the path. I just closed. In this case, the inadvertently artery was punctured, pseudo-aneurysm was made out, and the mouth was closed. Now coming to the true aneurysm, generally it happens with rope ladder technique and abnormal external remodeling. Downstream stenosis, this is what the most important point I want to highlight. See, brachial fistula is very easy, but if you make more than 5 millimeter, 6 millimeter diameter, then most of the brachial fistula, I think Girish was telling in the point, annotating same point just in his lecture, that by 6 months time, you will develop either high output cardiac failure or distal downstream stenosis. So make sure that if you are doing or your surgeon is doing, make sure that you are 5 millimeter or less than 5 millimeter adequate enough to have a good BC AV fistula. And sometimes high blood pressure, uncontrolled blood pressure, large arteriotomy I had already alluded to. So these are the common causes for true aneurysm I can attribute, but the majority of times we don't know the cause. So two classifications been put forth by two investigators, like Bellas et al. And Valenti et al. So both of them, whenever you see the literature, they are not widely followed. One is aneurysm is a morphology related, and this is aneurysm with thrombosis stenosis. This is a description. I am not going to detail for the paucity of time. So I made a concoction of both. This is the Bellas and Bayok. They both said 18 millimeter more than diameter thing. So here, now the practical classification. I just concocted. I thought this can be taken up by some research in our country to make it as a very useful one. It's a combined Valenti and Bellas et al. The true aneurysm is without stenosis. Many times we in stage 4 CKD we create a fistula. Then even without using it, it will develop a serpentine-like fistula. This hose pipe like uniform aneurysm, tortuous serpentine, but there is no stenosis in the distal. Here, only thing is you have to differentiate between high and low outflow. If it is more than 2000 ml outflow, then the likelihood of chance of developing HOF, then you might intervene by flow reduction. So here, AVF with no thrombosis or stenosis. This is what I told you, that first type 1. So this is simple, most very useful bedside test. Any AVF aneurysm, just do a limb elevation above the head. This will give a 90% idea that what we are dealing with. So this we fail to do most of the time. So it collapses completely. So however the aneurysm is serpentine, monstrous, if it is having good collapsing, then I will not worry about it. It's for just a asymptomatic, just for cosmetic purpose, I will not intervene. Those are type 2 aneurysm with the interaneurysmal stenosis. Very often we see in recent times with or without thrombosis. And AVF aneurysm with cephalic arch central arch stenosis. So this is what, see you most of the time AVF aneurysm is the treatment of choice is the intervention by surgical. If you go inside, you find that moment you flip up remove the sleeve, the redundant sleeve, proximally you find distal you find a very narrow segment. So what to do then? So these kind of scenarios we are caught between rock. In a dilemma. So this before that we could understand what is what. But before intervention, generally we'll do venography, will identify. But that is a general classification is all about. So sometimes after the stenosis, you get a complete narrowing. Then you have to go for a turn down procedure. So this is with the thrombosis. This is a central vein stenosis with dilatation. Here, see the clinical sign is very important. You have a tense AV fistula, does not collapse in occlusion, does not collapse in elevation, no pulse augmentation, so not some typing error, and prolonged bleeding after decannulation and high venous pressure. If you have aneurysm with these kind of things, you can suspect central vein stenosis, you can investigate. But the problem here is you have to estimate the flow. If you open the central vein stenosis, it's like opening the floodgate. Patient might go for high output cardiac failure. So you have to weigh the balance. Individual case is managed based on the merits and demerits of particular clinical scenario. So this is a narrowed segment. This all with clot. This is a typical case. One is collapsing, another is not collapsing with on elevation. So here definitely the next choice, we don't know whether you have to go for the flow reduction, then you remove the stenosis. So that's why the definition is not clear. Even the surgical, management of AVF aneurysm is not clear. It's all based on individual cases. So this okay. See another important point, the type 2 aneurysmal with the central vein stenosis. If you do a Doppler, instead of continuous rumbling flow, you will get a typical high-pitched systolic and diastolic difference, and you will get sometimes, biphasic flow instead of monophasic. Just above the baseline, you will get a biphasic flow. This is a clue in ultrasound, that this patient may be having central vein stenosis. But unfortunately, I don't have audio. If I play the audio, you can see the sound. This is what in Doppler helps in our clinical judgment. So type 3 AV fistula aneurysm is a partial thrombus and complete thrombus. Here you have aneurysm. You have just to do ultrasound for routine sake, you will get some thrombus hanging over the wall. But though there is no obstruction, but if this needs a sleeve removal along with thrombus, so it needs surgical intervention. Another is a partial thrombus, another is a complete thrombus. So here you have to abandon the fistula, go for the next choice. Another type 4, AV fistula aneurysm with focal aneurysm. This happens, this is often we see because of poor needling technique or with secondary infection. The simple thing is you go and resect the aneurysm and make your fistula patent. And another is a complete thrombus. So this is a fourth very practical classification. This I devised over the years of observation based on both Valenti and Ballas classification. So the treatment is AV aneurysm is a benign process. Most of them not very stable, asymptomatic. AV pseudo-aneurysm and AV fistula aneurysm managed purely on clinical findings and USG with available facilities. How you are trained and what is your team is supposed to have such kind of quality of managing these patients. Venography is indicated where outflow stenosis suspected, when intervention is anticipated, prior to surgical and non-emergency. In an emergency, you have to go and tie the things, right? In a non-emergency, you can go for venography, and prior to endovascular stenting. Venograph, someone was, I think Himansh was making a point today morning, right? That, instead of CT, you can go for a venograph, a dynamic thing you can understand, a roadmap to the access outflow through to the right atrium as well as allows a dynamic assessment. So better to go for a dynamic flow assessment than the static CT angiogram. The three main indications for true aneurysmal intervention is a group 1, group 2, group 3. First is AVF causing some discomfort. People might be having very abnormal, cosmetically disfiguring, then you have to listen to the patient choice, or you anticipate some kind of impending trouble, you can go for it. AVF aneurysm causing bleeding risk. And some third is very important, access flow issues, whether it is high flow or outflow stenosis or low flow. In high flow, you have a heart failure or you have Steele syndrome. Either way, you have to intervene. In the low flow, maybe feeding artery may be thrombus or juxta-anastomotic. Here also you have to intervene. Otherwise, the distal AV fistula will go for thrombus because low flow. The outflow, you have the central vein stenosis along with the intra-aneurysmal stenosis needs intervention. But most of the time after intervention, this will have a recurrence. Then you have to plan for other side fistula or other option of RRT. So this is a general indication for aneurysmal intervention. So if I have this, suppose I presume this patient is 8 years old AV fistula, I see this kind of aneurysmal. I will not go for intervention if it is soft, non-tender, no increase in size recent times, no functional problems, collapse on elevation, no HOHF, no Steele phenomenon. Why should I intervene? So just watch. So all aneurysm not dangerous. There are 5 danger signs. Rapid growth, when a bump turn into cone shape like things, and a painful like a lump, like a blood infiltration in the tissue, hyperpulsatile, and skin devascularization like skin ulceration, blackish. The simple thing is when skin and subcutaneous get adherent and become one layer and some SR-like formation forming, it's a sign that it's going to rupture soon. So these are the danger indication, and of course ischemia. So these are the 5 danger signs. When there is no intervention required, here intervention is required. So when you adopt a conservative management in asymptomatic patient, the 2 things, you have to keep periodically investigate for outflow stenosis, and modification of cannulation sites and technique you have to implement in your protocol. So generally the type of treatment is 5 types: aneurysmography, or plication, or resection, or ligation and endovascular report. These are the 5 available things. See, most of the time AVF aneurysm requires surgical repair, but you can go in a frail patient's endovascular because over the like a covered stent, through the stent it's very difficult to cannulate, but in difficult frail patients you can do it. Ligation is a simple ligation, and you can use a prosthetic graft, and resection also when any suppose the facility is not available, you are only trained in kind of resection and go for the other side, that's also feasible. But most of the time, even 2 years ago, I was doing that kind of work only. Now I am trying to do some kind of aneurysmography. It all depends on your experience and the pressing necessity of the patient's clinical situation. There's all these things. And aneurysmography, you can use even stapler needle. Stapler they are using for the gastric sleeve, gastrectomy for the bariatric surgery. That kind of thing you can use for the aneurysmography. Or simple, you can resection and anastomose and all these things you can do in aneurysmography. But this is a general outline. It depends on individual patients. So in a nutshell, there is no standard definition for AV fistula aneurysm. Natural history of different types and growth not defined. The best treatment modality is not clear. Most of the treatments are guided by clinical experience rather than evidence. So surgical approaches remain the mainstay of treatment. endovascular stenting and the stent cannulation can be considered in frail patients. But ultimately, the mantra is you have to preserve the patency and prohibit prosthetics. That means you don't use prosthetic material, you invite more trouble to the patients. So my sincere thanks to Girish Shetty, all the images, because I don't see this kind of aneurysm, because the institute is a huge loading is seeing every day 1 or 2 patients are coming with aneurysm, with central vein stenosis, it needs intervention. So I sincerely thank my friend, he contributed all the images except 1 or 2 images. Thanks.
Thank you, sir, for your nice elaborative talk on the